Who feels like they have a really good idea of what PT roles are in injured cases? Yes. My PTs know what's happening. How many of you would say, I don't really know a lot, need to know more? Good. A lot of hands. That's good. The rest of you don't care. It's Friday. Let's get out of here and wrap this deal up. I get it. Let's talk about them. Let's talk about the different roles of PT in the injured worker case. A lot of these cases are going to be closed without any PT intervention. No OT, no PT. Cuts, scrapes, abrasions, bruises. Those might go to urgent care and be resolved without any need for therapy intervention whatsoever. A lot of cases do, though. Those are the ones we want to talk about today. Super complicated cases oftentimes require multiple therapy encounters. And I know that as an employer, that can be frustrating to you. Questions like, why are we going to therapy? And then about 4 weeks later, why are we going to therapy again? And then after surgery, now we're going to therapy again. How long is this going to last? Multiple encounters. The simple cases, we don't have to worry about that. They're going to resolve on their own. Hard ones, surgical cases, they're going to be in therapy probably up to 4, maybe 5 different times during the rehab process. How many of you had a complicated case? Anybody had complicated cases? We don't get the easy ones. We want the easy ones. We don't get them very often. Phases of treatment for the injured worker. These are the 5 different phases that I feel like, this is not stuff that we learn in the book, this is experience-wise, this is what we see. This is how these folks come into the clinic. Number 1, the acute phase, immediately after injury. It's going to last for a defined amount of time. Number 2, the subacute phase. So we're kind of getting a little bit better, but we're not better enough. We're not able to go back and do our job. Heaven forbid we get to number 3, the post-surgical phase. So now we've got a surgery. We're doing some rehab after surgery to return to work conditioning or work hardening phase. And then number 5, the dreaded FCE. Who's seen an FCE recently? Are we still doing FCEs? How many of you know what an FCE is? Not very many of you. Okay, some of you, but not very many. We'll talk about the FCE here in just a few minutes. Acute phase, right after injury. Typically, we're looking at the first 4 to 6 weeks after an injury. If we're going to have physical therapy at this phase, it's potentially going to be ordered by your port of entry provider. So we're going to go to urgent care. We're going to see the quote-unquote work comp doc. How many of you have heard that from your employees? Now they sent me over to the work comp doc. They don't want to help me. They just want to send me back to work. Work comp doc. In the acute phase, we have very limited diagnostic testing. Usually, we don't have any testing. If we've had a fall or if we've been involved in a motor vehicle accident, we might get x-rays during this phase. Typically, pretty limited. We're going to receive an order with a diagnosis. It is very generic. In reference to a knee, what would be a generic diagnosis that we would see? What was it? Knee pain. That's a great one. How about another one? Strain. Knee strain. Knee pain. Leg pain. Back pain. Neck pain. It's very generic. We see these all the time. Patients, employees do not like generic diagnoses. Because when we type that into WebMD, we get all kinds of wild responses. But at this place, we're still working with a generic diagnosis. We're still right after injury. If this patient is going to be sent to therapy, it's going to be a 4 to 12 visit prescription. Typically, very short. A lot of the ones that I see are 6 visits with a return to the doctor in about 3 weeks. So we're going to spread those out. Pretty superficial in our treatment. If they are limited in their function, that initial provider should give you a work status. We should have a determination. That should come back to the employer. It should come back to the insurance company. These are the work restrictions that I'm giving you. How many of you see those work status worksheets that come back? How many of you wish you could change what is on the work status worksheet? Yes, all of us. Look at this dirty word here at the end. Maybe off work. Ugh, we don't like off work. Off work is bad. Do we see that though? Does that come back that way? Depends on who our provider is. If it's a work comp provider, if it's somebody that is savvy with the work comp experience, they're going to know we need a work status worksheet. We need to get that information back to the employer. We need modified duty restrictions. Maybe off work, depending on modified duty program. So modified duty program. Employers in the room. Who has a modified duty program? Yes, hands are going up. That is good. You need to have a modified duty program. It saves you money in the long term. Is it hard to provide modified duty sometimes? Modified duty program. Who doesn't have one? Who doesn't offer modified duty? I'm curious. Yeah, it's okay. Some great resources in the room, so look around. The people that had their hands up, if you have questions, what would a modified duty program look like? What should we do? What didn't work? Who had a modified duty program that was awful and you'd admit it? Anybody have one that was like, that stunk? I wouldn't do that again. Nobody? Skilled group in the room. I like it. It's good. You guys are awesome. Okay, acute phase. So we may be off work if we don't have a modified duty program available. Acute phase of therapy. These are our goals. First 4 to 6 weeks. These goals are very general. We're looking at decreasing the inflammatory response that's caused by the injury. So we've probably got some type of swelling, some type of bruising, some type of response that we can actually see and feel. And the employee, they see it, they feel it as well. PT standpoint, we're also going to promote available motion and prevent functional loss. When a shoulder hurts, what do I want to do with that shoulder if it's mine? What do I want to do with that shoulder when it hurts? I don't want to move it. It hurts. I want to hold it right here. I don't want to do it. Okay? Part of the PT component would be promoting the available motion, preventing more functional loss, because we can have secondary problems from the motion loss. Number 3, patient education. I say this is the most important goal during the acute phase, and actually throughout the entire course of treatment. You'd say, that's crazy. I'm sending them over there for you to make them better. I spend more time educating people and talking to them about their case than I do in actually developing their treatment plan. I feel like people that come in this acute phase, they don't know what's going on. They're kind of being shuffled around. They don't feel like they've been represented well. They've been sent to the work comp doc. Now they're going to the work comp therapist. You're in network with those guys. They're using you. You're in their pocket. I get it. I hear this all the time. This is what we hear. I'm going to set them down. I'm going to talk to them. I'm going to listen to them. Patient education. Hopefully, we're going to resolve symptoms in the acute phase. First 3 weeks, man, it'd be awesome. A little knee sprain, knee pain. Hopefully, it gets better. They move better. I send them back. They get released. All is good. I'm going to assist the provider with the diagnosis. Why do I say assist? Any takers on that question? Why do I say assist my referring provider? Yes, ma'am. Okay, sure. So I'm telling the doctor what's going on, what my opinion is on that. Why did I highlight assist in that question, in that point? How many have had a physical therapist in the past? Your employee was sent to them, and the therapist told them, you have a blank. You have a torn rotator cuff. You have a herniated disc. You have an annular tear in your cervical disc. Has anybody ever had that happen? Then you're sending your people to the right place, because that should not come back to you. It's one thing that really aggravates referring physicians when the patient comes back and says, well, my therapist told me that I have a torn ACL in my knee and you have not done an MRI yet. That is very aggravating to the physician. So I'm going to assist the provider with diagnosis. And that's going to be a backdoor type assist. Probably not going to relay that information, if it's obvious to me, to the employee. I'm going to get with the doctor and let them know. Acute interventions. What are we going to do to or with the patient during the acute phase of therapy? Modalities. These are things that are passive. These are things that we're doing to the patient, and it feels good. Patients love this stuff. Heat, cryotherapy. Who knows what cryotherapy is? Yes. Cold, that's right. Cryotherapy, fancy word. That's our PT term. It's ice. It's cold. Compression. So ACE bandaging, compression devices that help to bring swelling out of the tissue. Ultrasound, electrical stimulation, phonophoresis, iontophoresis, those last two are ways that we can deliver a corticosteroid to a tissue without a needle. So it's transdermal through the skin. Passive treatments primarily. We may do some splinting, wrist splints, compression sleeves on the knee, maybe a shoulder sling. Probably not, though. We don't do many shoulder slings anymore. It's kind of out of vogue right now. Gentle range of motion. Notice these last 3 points are all gentle. Gentle range of motion. Gentle isometric strengthening. Gentle strengthening. Gentle manual techniques. Why is it gentle? A couple reasons. Don't want to overdo it. I don't want to make the patient worse. We're still in the acute phase, so they still may have some swelling. These people are in pain. You know, they're going to tell us they're 5 of 10 pain, 8 of 10 pain. I'm not going to have them doing strenuous activity at this phase, right? Plus, I really don't have diagnostics. I'm not sure what's going on. I may have a good idea. I've done my evaluation. I'm treating them. I think I know what's going on. But I really don't have good diagnostic testing yet, so I'm not going to get aggressive with these folks. Here are some gems. Acute phase questions. First one. This is the employee. Why do they send me to therapy when they don't know what's wrong with me? As an employer, have you heard that before? Why are they sending me to PT? They've not done any testing. They don't know what's wrong with me. They send me over to PT. That guy's mean. He makes me climb the wall with my arm, do all this hard stuff. Why do they send me to therapy? Number 2, this is a doozy. We get this one every time. Why have I not had a blank? So we've got MRI, CT scan, all of these diagnostic testings, because they've done some homework. Somebody's talking to them. You know, well, I had similar pain. I needed an MRI. Why have I not had my MRI? Because you're 2 weeks in. 80% of them are going to get better if we don't do anything. If I sent you home for 4 weeks, you'd probably be fine, right? Number 3, why are they sending me to work? I need to be off. Do you have employees that are chomping at the bit to come back after injury? Typically, no. Not really. Man, I'd like to be off. That off is good. Get to hang out with the kids, be around the house. Need to be off. Number 4, we get this one frequently. What if I can't do the light duty work? So we're assuming here that we have modified duty available. I hear that all the time. Patients come into me and they're like, man, it hurts. You know, I'm still doing an 8-hour shift. Going home, I'm miserable. What if I can't do the light duty work? They're getting patient education. I have to sit down with them and talk to them, kind of walk them through, hey, you need to communicate this to the doctor. I will help you communicate that. When you tell me those things, I'm putting that in your progress note. There's a record of that. I'm sending that over to the doctor. He says he can't do his light duty work. Do we need to revisit that? May need to call the physician. Are you talking to your immediate supervisor about their light duty work, right? Because we get that side of it too. Hey, I've got a 10-pound lift restriction. They're asking me to do 15, 25, 30 pounds at work. What do I do? That's a tough one. In that case, it's the employee's responsibility. They have to be their own advocate in that instance. So these are the acute phase questions that we typically see. When we're looking at work restrictions, oftentimes the physician is making a best guess. They're having to guess what can they do, what is reasonable. And in this acute phase, it's brand new. So they may have to modify. They may need to make some changes. So the patient's advocating. Hopefully you have a relationship with your employees to where they can come to you and tell you those things. You need to advocate for them. It is a two-way street. Sub-acute phase. So the initial inflammatory response is mostly over now. They're probably still painful. They probably have some limited motion in their affected joints. This is going to last anywhere from week 4 to 6. until resolution of their symptoms and return to work, or surgery, heaven forbid. Time frame on the subacute phase can get long, more difficult to define. Can't say, well, we're at the end by 3 months. We're over it, because some things are more problematic to treat. Low backs are hard. Low backs are really tough, I'll be honest. Subacute phase, those low backs are hard. We're trying to progress them along. We're trying to move them a little bit more, and they're not responding well to it. Typically, in the subacute phase, we're going to get a transfer of care either to physiatry or to an orthopedic surgeon or to a neurosurgeon. We're going to send them out to a specialist. Okay, so we're no longer at urgent care. We're no longer at that initial port of entry physician, but they're getting referred on. Okay, does everybody know what physiatry is? You need to know what physiatry is. Physiatry is a great term. I love it when we get prescriptions for PT from physiatry. So we do have some questions. Some people do not know what physiatry is. Physiatry is a rehab specialist. So they're non-surgical typically, but I think of them as the director of care. Where do we go? So I'm now in subacute phase. I may have had an x-ray if I went to the urgent care or if I went to ER initially. We're well past that now, but they're not getting better. They're still not able to return to work. Physiatry is going to look at that case and they're going to say, okay, what would be the appropriate testing? Is it appropriate to do an MRI? Is it likely that they need back surgery? If so, then I'm going to start that conservative model of care. They're going to do the most conservative treatment strategies first, and then each step in their treatment program is going to become more aggressive or less conservative, however you want to look at it. Okay? So they're going to order the testing. They are specialists at that. We've got 3 physiatrists in Springfield that use us frequently, and I know what they're thinking. It's interesting because when I see it coming from them, I know that we're well involved, and I try to tell my patients that, hey, you don't be afraid. I know this doctor. They're going to take good care of you. Once you get to the physiatry phase, then things are going to kind of get ramped up in terms of finding out specifics, more clear diagnoses, and more specific treatments. Does that answer? Everybody know what physiatry is? You need to know what a physiatrist is, because that's where I like for these folks to go. They may not be surgical. They may be referred on to specialist or to surgeon from physiatry. That's a great intermediate step during the subacute phase. Directors of care. Now we get the more accurate diagnostic testing. So now you're getting the request for an MRI. Now we're looking for a CT scan. What other tests do we have? Nerve conduction studies, possibly. So your repetitive folks, they may be getting their nerve conduction studies for carpal tunnel injuries, that sort of thing. Now we're getting a more clearly defined diagnosis from that provider. So now we're honing in. I have a partial tear of my left knee medial collateral ligament. Annular tear in the L5-S1 disc without effacement. So we're going to get some good diagnostics. Now we're honing in on where the problem is. Subacute phase, we've talked about it. The inflammation is pretty much over. Swelling is getting better. They should be able to perform some fashion of light duty work. Even if it's sitting in the cafeteria reading safety manuals, they can do that. They may have to stand. If it's a back patient, they may have to stand there and read them. Okay? Light duty work. Subacute therapy goals. I'm going to try to move away from passive treatments. Again, passive treatments feel good. Who would like to have a massage? Sign me up. I want to do that. That's good. Rub my back, put ultrasound on it, and then put heat with electrical stems on my lower back. That feels awesome. Who wouldn't want that? But now we're subacute, so we need to be moving away from that. We want to do more active treatments. I want to get the patient moving while they're in therapy. They need to be on a treadmill. They need to be on a new step machine. They need to be walking around if they can't tolerate those other two. They need to start their exercise, some fashion of active movement where they're involved in it. I'm going to emphasize on motion, strength, and function of the affected joints or structures. Subacute therapy interventions. Talked about it. less physical modalities. Let's get away from the passive stuff. Let's get them moving. We're going to start our exercise program. So they're going to be doing lumbar stabilization. If I know that he has a torn ACL, then they're going to be doing lower extremity strengthening. I'm going to try to promote as much motion around that joint as I can if in fact they have to have surgery. Manual therapy. I'm going to have my hands on the patient probably. So we're looking at soft tissue abnormalities, deep tissue mobilization, instrument-assisted soft tissue mobilization, those types of treatments. So still some hands-on, far more activity, far less passive treatments. Questions about that stuff? Subacute, not surgical yet. Questions? Anyone? Subacute questions, here we go again. Am I going to need surgery? WebMD says blank, right? What does WebMD say? Everything on WebMD ends up with what? What's one of the options? You're dying, or you need surgery, or you have cancer. Everything. It doesn't matter. My pinky hurts. It could be cancer. It could be. It could be cancer. WebMD says so. These are tough questions as a therapist. That's not my decision to make. Do I need surgery? I can't. That's not my decision. If you have a torn ACL, you need to have it repaired. You know? If I have a torn rotator cuff, it needs to be repaired. But that's not, ultimately, that's not my call. Okay. Why am I not getting better? A whole litany of reasons, which probably I can't say out loud. You're a whiner. You're a complainer. You don't want to go to work. You hate your job. You kick your dog in the morning, right? These are all reasons I'm not getting better. The doctor says my MRI is normal, but the MRI report says that I have a blank. Why is that? How many of you have heard that one? You guys hear that? I know my providers do. The providers hear that. So because here's what's going to happen. The employee goes for their MRI. They go for their follow-up 2 weeks after their MRI. They sit them down and say, hey, MRI looks good. It's normal. The employee immediately calls the MRI company, and they get a written report. And if that employee is over 30 years old, they have findings on their MRI. All these really bad things, bone spurring, all these horrible degenerative disc disease, degenerative joint disease. You know, it's part of it, but it's not normal. So why the discrepancy? Well, there's a reason to that. You know, the physiatrist, they're looking at, is there a reason to do surgery right now? Is there a reason that I need to send you for a surgical consult? And oftentimes, these are normal processes of aging that is not causing their leg pain in the event of a low back patient. So it's not normal, but it's not necessarily something that they always share with the patient. Why am I on modified duty? I need to be off. We're going to repeat that one. We'll hear that all the way through this entire case, right? Man, I'd rather be at home. I don't want to be in the cafeteria reading the safety manuals. Post-surgical phase. So our acute treatments didn't work. Went on. We've seen physiatry. We've seen a specialist. It's not getting better. Had to have surgery. Post-surgical phase, surgical intervention has already occurred. Therapy protocol is sent to the treating therapist because every surgeon makes absolutely sure that the treating therapist has a protocol specific to that procedure. Is that accurate or not accurate? Never accurate. We have to dig and pry and cry and scream to get that from the doctor. We want to treat the patient the way that surgeon wants them to be treated. And there is some variation between surgeons. But we're going to get that therapy protocol specific to that surgeon. If they don't have a protocol, we have some generic protocols that we use to make sure that we're moving along at the correct rate. Got a new PT prescription now. There's going to be a little bit of time after the surgery when they're still bandaged. They've still got their post-surgical bandaging on. They've not gone for their post-op visit yet. So typically that's a couple of weeks after their surgery. We're going to get a new PT order. The ones that we typically see be 2 to 3 times a week for 4 to 16 weeks. 16 weeks. It's a long time, 4 months. On the rotator cuff repairs, that's a guarantee, 16 weeks. A lot of surgeons will automatically write that right out of the gate. Some don't. Some prefer to do 4 or 5 weeks at a time. But those doctors that do that, I know for a fact, they write them the same way every time. I'm thinking of one surgeon in Springfield. He writes the same thing every time, 2 times a week, 5 weeks. They have a doctor's visit at exactly the date that those 10 visits are up. We get a new prescription written for another 5 weeks, and then we get a third one for 5 weeks. He writes them the exact same every time for rotator cuff repairs. Post-surgical phase is long. Now, we've got new post-surgical restrictions, so we need to revisit our modified work. We may need to look at that again. What can we offer that employee? What can we have them do? I don't want them sitting at home. Please don't let them sit at home. I'm serious. This is something that we've been talking about in our office. Just in the past year, I've noticed a huge increase, and it's a problem for patients. And they're the ones telling us. I'm not picking on them. But they come in and they're like, man, I've been off work for 6 months, and I have put on 30 pounds. It happens. So now I'm trying to rehab them for this. They put on 30 pounds. They feel awful. They get winded walking to the refrigerator. Honestly. Not making it up. It's how it goes. It's horrible. Get them in their boots in the morning and get them on a job site somewhere. Keep them in the mindset of working. Dr. Ted Leonard, he's a physiatrist in Springfield. He used to give this talk years ago, and I loved it. It stuck out in my mind. It's probably been 20 years ago. It was the top 10 risk factors to return to work in work comp cases. The thing that stuck out the most to me about that talk, nowhere on the top 10 list of risk factors for returning to work was what? What would be your guess? It was not on the top 10. You'll think it's the most important thing. It was not in the top 10. What was wrong with the patient? Had nothing to do with their likelihood of returning to work. Didn't matter. Had to have their leg amputated? Didn't matter. 4-level back fusion? It's not one of the top 10 risk factors. It's all these psychosocial issues. Am I single? Am I married? Am I male? Am I female? All of these other things come into play. How do I feel like do I feel like I'm being taken care of by my employer? It didn't have anything to do with what was physically wrong with the patient. So, longest duration of physical therapy treatment, post-surgical, goes on and on and on. Unfortunately, really, it doesn't go on for no reason. We're looking at tissue that's trying to heal. It takes a long time for it to heal. On a rotator cuff, it takes a long time. We're waiting on critical phases for tissue healing. Before it takes a long time. There is a rhyme to it. It's not like we don't make it up and be like, well, let's see if we can make a lot of money off this case. Let's keep them in here for 6 months. Post-surgical therapy goals. Okay, so here they're coming in. Protection phase. Obviously, I need to protect their surgical intervention, whatever that is. Rotator cuff, they're probably going to be in a sling for 6 weeks. At least when they're out in community. Most of the doctors now don't want them wearing a sling at home. I'm going to protect their surgical repair and their incision. I don't want infection. I'm going to start passive range or gentle active range of motion. So this is a protective phase of treatment. The last thing I want to do is send a surgeon their patient back and have undone their surgery. That is a bad day for the therapist. Really bad. I don't want to do that. Control their post-surgical pain and inflammation. There may be some modalities. They're probably going to have to do some stuff that feels good because they're going to be pretty limited here. First 4 weeks of therapy following their surgery is where we're looking at that protection phase. We're going to immediately go into their strengthening phase, motion. We're going to start ramping things up. Progressive strengthening program, gradual increase of resistance, more aggressive with time, 4 weeks to 12 weeks of post-op. That's kind of the bulk of where you're really doing stuff in therapy. Function and endurance phase. So now we're doing strengthening, but we want to make it functional. We want to make it similar to what they'd have to do at work. More weight, more functional. We might have like balance activities, dynamic functional, so gentle lift and carry, push, pull, those sorts of things. Things that they would have to do at work. Number 4, work hardening or conditioning. Simulated work activities. Hour and a half, 4 hours, possibly 8 hours. Anybody do 8 hours? You guys ever get any 8-hour work days? 8 hours of work. Hardening. So we're going to simulate what they do for a job for 8 hours. So if they're a driver, we probably got them sitting for a long period of time, acting, some type of simulated driving. If they lift and carry, we're going to have them doing it with rest periods. It's not like we're going to crank on them for 8 hours. But it's going to be tough. We're trying to harden their body and work on their endurance. We talked about the patients that are off of work for a long time. Oftentimes it's a result of the duration. That patient that's put on 30 pounds, can they just immediately go back to their normal job? No, it's tough. Their endurance is in the tank. It's not good. Work hardening, work conditioning. Step number 5, FCE, functional capacity evaluation. May or may not be performed. Kind of hit or miss right now. It seems to me in the past, well, certainly in the past 15 years, there are less FCEs performed. A number of years ago, it seems like every complicated case got an FCE. We got a lot of FCE reports that were determined to be either unreliable or invalid. So in other words, either the results, if someone's giving poor effort, then it's an invalid test. I tested them, they did it, but because they weren't giving good effort, those results are unreliable. So you paid $800 for an exam that was immediately thrown out because it was unreliable. If I can't rely on the information as being accurate, or if they weren't giving good effort, then I can't use that to say whether or not the patient can return to work. To be honest, from the PT standpoint, we do our best. My clinic doesn't do FCEs. We don't do these. We're primarily a treatment clinic, so I don't do FCEs. But the folks that are doing FCEs, they're doing everything possible to make them reliable and good tests, believe me. They go to great lengths to make these things useful and reliable and valid. Sometimes they're not. Last point here, should always be performed by a therapy provider other than the treating therapist. That's my personal opinion. If I've seen this patient for the previous 5 months of rehab, I don't want to do their FCE. I want a completely different set of eyes. I think it helps. That's my personal opinion. I would rather have somebody else do the FCE. I just think it works to your benefit to have somebody that's completely unrelated to the case. They've never seen the patient before. That way there are no preconceived notions. People are with me an hour, hour and a half a day, 2 to 3 times a week for 4 months. I get to know them better than anyone else involved in their care. By far, I can say that with utter confidence. We talk about their dog, we talk about their fishing trips, we talk about their kids, we talk about food. We talk about food a lot at our clinic, actually. But I spend a lot of time with these folks. I don't want to do their FCE. I think that it kind of muddies the water as to their effort. They know what they can get away with me, but they don't know somebody that they've not been with before. So that's my recommendation on that. Post-surgical therapy questions. Will I ever be finished with therapy? That's the patient. And the employer calls me 5 minutes later. Are they ever going to be finished with therapy? This is killing us. You guys are killing us over there. Oh, will I get all my function back? People want to know. They're scared. They're nervous. Folks that have been at their job for 20, 25 years. You get the employee that's 5 years out from retirement, right? These things happen. It's tough. It's hard. They want to finish. They get insecure. They get nervous. Am I going to be able to do it? Am I going to be able to do that again? My favorite, this is not a question, this is a statement. My uncle had the same surgery, never worked again. You ever get that? Your employees are getting information from someone. They're getting voices. They're speaking into their life. They're hearing information. Make it from you. We'll talk about that again here in a minute. But they've got a coworker that they're visiting with, right? Had to move some people just recently. Get them apart. They get in there and they start chatting. I'm getting treated worse than you are. Company's hosing me more than you. Honestly, it's a comparison. It's crazy. But we hear it. I'm hurt worse than you. I bet I go back to work later than you do. Happens. You think that's 100% real. Fit for duty testing. We touched just a little bit on modified duty. You got to have a modified duty program, I think. You just have to. It costs you some time. There's some effort involved in developing a good return to work program. Some financial investment involved. It saves you money in the long run. Fit for duty testing. Can the injured perform the essential job, physical demands of their job? Can they? Who makes that decision? Who makes that decision? Let me ask you this question. Do surgeons like to make that decision? Crystal says no, and she is right. They do not like that. Surgeons like to do surgery. They do. They want to do surgery, and then they want you off their plate. What? You're not better? Go see physiatry. They don't want to deal with that stuff. They don't like IMEs. They don't like ratings. They don't want to do that. They want you off their plate. So, there we are. Fit for duty testing. There's a pretty easy way, and we'll talk about it in the second half here. We'll talk about post-offer employment testing, and we'll kind of fit that component in with that. Okay, let's talk about two different painters. They're sort of made up, but they're sort of 100% real. I'll let you figure that out. I don't know. Sam and Chris are both career commercial painters with 15 years at their current job. They've done overhead stuff their whole life. That's what they do, commercial painters. Both are awesome employees. They're in good standing with their job, get along with their employers. Both of them are kind of like a team lead. Neither has a history of shoulder problems or surgery. Both of them had falls from a ladder, resulting in injury to their right shoulder. Ultimately, both of them had rotator cuff repairs with Mumford decompression and a bicep tenodesis. Both surgeries were performed by the same surgeon who's really good. He's good. Let's make an assumption about these two cases. They're the same injury. They had the same surgery by the same doctor. So their course of treatment should be the same. Let's make that assumption, right? Same intervention, same rehab, same outcome, same cost of care, right? Wrong. It's not right. It's not what happens. Got a lot of variables. What's that? Two different people, two different employers, right? Let's talk about it. Let's go into them. Sam's case. Sam is a great employee. Sam sustained this injury. He immediately went to HR at the end of the day. Turned it in, filled out his incident report. How many of you have a policy that you have to do an incident report within 24 hours? 24 hours. Get it turned in. We're going to be mad at you, right? Sam had an x-ray at urgent care, and he did not have a fractured humerus. It's good. Great news. Port of entry physician says, you know what, Sam probably can't paint. It's overhead. Better put him on some restricted duty. Give him some restrictions. His employer accommodated that. Put him to left-hand only work. Okay, Sam can still paint left-handed probably. But he put him on left-handed duty work. Work says, yeah, why not? Bring him in. We love Sam. Sam's a good guy. We're going to put him as a team lead for a while. He writes him a prescription for non-steroidal anti-inflammatories. So meloxicam, Mobic, Aleve, ibuprofen, something along that lines. He writes him a PT script with the general diagnosis, right shoulder pain. It's written for 6 visits over 3 weeks with the doctor's recheck to follow. Now, they use this PT clinic that's really awesome because they sent this order over, and that PT eval was completed in 2 days. That's awesome. Find somebody that does that for you. That's good. That's really good. They had their 6 visits of therapy that was spread out over 3 weeks. They returned to the doctor with a marked limitation in shoulder motion and 8 of 10 pain level while they're moving that right shoulder. So it's not good. It's not good. When they went for their follow-up, Sam's doc calls the PT and says, hey, what do you think about this? This doesn't look great. And the therapist, pretty savvy, he's been around a while. She's been around a while. She says, you know what? When I was doing the eval, he definitely had a positive empty can test, a positive liftoff test, positive for AC compression coming across the front. Man, he was screaming. It was killing him. And his motion stinks. You know, it's possible they have rotator cuff tear in there. long-headed biceps. And boy, that really bothered him. So gets off the phone with the PT. He says, you know what? I think you got something internal derangement. Something's going on in that shoulder. We don't know what it is. It's soft tissue. We had an x-ray. We know it's not fractured. We need to look at it and see. So he refers Sam directly to an orthopedic surgeon for consultation. That gets scheduled quickly. Sam is seen by the surgeon, requests an MRI based upon the dysfunction and the findings of the evaluation, gives him a new order for physical therapy. Now we've got a new diagnosis that comes out, possible right rotator cuff tear. So we're in that subacute phase of treatment now. We're seeing the surgeon 3 times a week for 4 weeks. We want to promote motion and improve the function. MRI is approved and completed 8 weeks after injury. And I would say that that's pretty quick. Anybody ordering MRIs? I mean, 8 weeks after injury, that's pretty quick. That would be my general opinion on that. That's pretty quick. 8 weeks. MRI shows he has a massive rotator cuff tear of his bicep tendon. He has acromioclavicular degeneration with bone spurring, very common, especially in people that do overhead work. If you're over age 40 in the room, you probably have some degeneration of your AC joint. Almost everyone does, unless you're a genetic miracle, which you can thank your parents for that if you are. Ortho requests surgery. But orthopedic surgeon says, hey, keep going to therapy because I don't want him to get a tight shoulder. Do some range of motion stuff with him. Keep him moving. Surgery scheduled 10 weeks after the injury. Surgery is successful. Underwent a rotator cuff repair, Mumford decompression. Mumford decompression, who knows what that is? Mumford decompression is a distal clavicle excision. They take off about the last ½ inch of your collarbone where it articulates with the top of your scapula. Kind of take that out and make a notch. It prevents you from having rotator cuff repair again in 3 years. Up until about 15 years ago, they wouldn't do that. If you had a torn rotator cuff tendon, they would go in and they would suture that back together, or they would pin it back down to the insertion point, whichever was required. They would leave this bone spur on top of the roof where that tendon lives, and then 2 years later, guess what? You get to have rotator cuff repair again because the causative problem was still there. They don't do that anymore. Almost everybody is doing the Mumford decompression. They're cleaning up the subacromial space where that tendon lives so that you don't have that problem again. You actually, the surgeons would say you actually get some years back. You're getting a 10-year younger shoulder after this. Had the Mumford decompression, bicep tenodesis, so they had to move where the long head of the bicep tendon inserts onto the humerus. They moved it because it was pulling at a tear in the labrum at the top. Sam returns for follow-up 2 weeks after the surgery, so we're post-op. Comes back for his follow-up, receives new work restriction. Employer again accommodates it because Sam's a great guy. New PT order, 2 times a week for 16 weeks. His PT's a genius. Sam's working really hard. Modified duty, everything's going well. Rehab's awesome. PT turns out well. Motion and strength return to normal levels. Because Sam's employer is on the ball, they've got this return to work fit for duty testing because they do post-offer employment testing. And they use their post-offer employment testing as their return to duty test. So they've got all this paperwork in place. Doc says, hey, Sam, do you think you could do your job? He says, yeah, I think I could do it. So they call. They get a copy of the test. Guy goes for the test, this return to work test, passes it. He's ready to go. Sam performs his fit for duty test, returns to full duty 28 weeks after injury. So we're 7 months in on a rotator cuff. And I would say that's pretty quick, actually. That sounds like forever. That's probably about as quick as you can get it done because there are some delays along. 7 months. Who's seeing faster than 7 months return to work on a rotator cuff tear? Anyone? If you do, I need to know who you're using because they're geniuses or they're cheating. 28 weeks. That's Sam's case. Best case scenario. Who would like to have cases like that? Man, I would. Sign me up for that. 7 months, but that's as good as they can turn out. The Chris case. Chris falls off the ladder, hurts his shoulder, goes to his supervisor. The supervisor says, man, can you finish out the day for us? We're shorthanded. Shorthanded. And they're also on this huge job. They're about 2 weeks out from having a big job finished. So the soup says, hey, man, we really need you on the job. Can you hold it together for 2 weeks? He's having 8 of 10 pain and his shoulder's killing him. It's not going well. But Chris is a good employee. He's trying. He's like, man, I'll suck it up and try it. Let's do it. After 2 weeks, though, he goes to the HR department, and he fills out his incident report. He gets reprimanded. Why? Why did he get reprimanded at HR? He didn't fill out his incident report in 24 hours. Timely reporting. It's our policy, right? So now they're upset with him. They finish up their job on that 2 weeks. In between the job sites, between that job and the next one, Chris is told, hey, why don't you take a couple weeks, stay off, use some PTO, see if it gets better. Sounds crazy. Does that happen? It 100% does happen all the time. I see it all the time, more often than I do Sam's case. Still not sent for a medical consult. Chris returns to work for the next 2 months, really can't do his job, but he's getting by. He's making it work. He feels as though he's not being taken care of. He's out of his PTO, no more paid time off. He's out. He's not getting better. Chris is having a bowl of ice cream. It's Wednesday night. It's ice cream night at his house. Watching the 10 o'clock news. On the 10 o'clock news, Chris sees 4 different commercials. One of them is a gentleman. He's a handsome chap. And he is a doctor, surgeon, and a lawyer. Okay. That's the first commercial he sees. Next commercial he sees is this guy out on this flowing hills up near El Dorado Springs on his family farm, Century Farm. You guys see that one? Who's that one? Anybody? Nobody knows that one. Nailed it. Well, I won't say his name. That's fine. We're not gonna do that. But he sees him on these flowing hills up in El Dorado Springs on this beautiful farm. The third one, he's got Travis Kelce out there, right? He's eating a Twinkie out of Travis Kelce's hand. It freaks me out. That commercial, I can't stand that one. The rest of them are pretty cool, but when Travis shoves that Twinkie in his mouth, I can't deal with that. It's weird. I don't like that. You know which one I'm talking about. The fourth one, let's see the fourth one. This is in the 10 o'clock news, and it happens every night. The fourth one is a little bit older commercial. It's a coffee cup falling to the carpet and banging into the floor and spilling the coffee. He hired blank law firm. Oh, no. What are we going to do? All right? So Chris seeks out legal representation. As a result of that, Chris is advised to only correspond through the attorney's office. Oh, boy. Things are going sideways now. So now Chris can't talk to his employer, can't talk to the insurance company. Everything has to go through the legal office. He's first seen by the work comp doc at 3 months because his attorney got things heading in a direction. First seen by work comp doc at 3 months. Conservative care model is initiated. PT is ordered. Then things get kind of normal, except for now we've got this communication lag. So instead of them being able to just call and say, hey, Chris, you need to show up over at therapy tomorrow, now it has to go through their office. So things take a lot longer. It takes 2 weeks to get it approved. Another 2 weeks for PT to be scheduled. 4 months before he's touched by a therapist. You say, oh, that can't happen. Happens all the time. I see it all the time. Got a case right now that's 18 months in, just had surgery. 18 months in. 4 months to start his PT. Same PT and conservative treatment course, so he still has to go through PT, except it's not going well. This is not good. Has the same MRI findings. He's got a massive rotator cuff tear. Chris has developed adhesive capsulitis, so he's got a frozen shoulder. Who's heard that term? Frozen shoulder. Frozen shoulder. So we've got a capsular pattern. They can't externally rotate or abduct their arm. Doesn't go well. So now when Chris tries to go overhead, he's giving you one of these things. It just won't go there. Can't get it there. Can't get it there. He's got he's got a rotator cuff tear, but now he has a tight joint capsule. It's not a good combination. Chris has surgery by the same surgeon as Sam, but his surgery actually occurred at 8 months, 2 weeks. Different employer. They don't have light duty program, no modified duty. They said that he's off work 100% until he's 100% released by the surgeon. 100%. No light duty. So he's hanging out at the house. Chris is no longer employed by the company. Did he get fired or did he quit? I don't know. Either one. Pick one. Doesn't matter. Same result. PT is not going well. His joint capsule's super tight. He has poor tolerance to motion. Strength is not improving at all. At 10 weeks after surgery, he undergoes a closed manipulation under anesthesia, so the doctor takes him back in, puts him to sleep, grabs a hold of his arm, touches the table with his arm in that direction, comes up that way. All types of zipper noises and tearing of scar adhesions inside of his joint. Sounds awful. It's really bad. Happens. Closed manipulation. Chris has a standard 16 weeks of PT. He's done with PT, right? Nope, because it's not good. Still not good. Chris isn't motivated. He doesn't have a job. He's not returning to a job. What's his motivation now? He's no longer employed there. Why do I get better now? Total cost, if it costs more money, I'm actually going to get a better settlement at the end of this deal now. I'm not going back to work for him. What does it matter? Requires an extra month of rehab therapy plus 1 month of work conditioning because he's put on that 30 pounds that we talked about earlier. We're 14 months in. Doctor requires an FCE. They don't have any type of return to work in, and he wouldn't have passed it anyway. So now we're getting a FCE. It's scheduled, performed, and the report is submitted within a month. That's probably a reasonable time frame. So now MMI is declared for this gentleman at 18 months after his injury. You think that can happen? It does. It's crazy. It shouldn't happen. It does happen. Happens all the time. Case highlights. Injuries were exactly the same. Surgery was the same. The PT component and the rehab costs were increased because of the delay of treatment. So he had two problems. He had the surgery, but he also had tight joint capsule. Tight joint capsule is just as damning as the surgery. Actually, it's more problematic in my mind. Because the rehab is easy. The tight shoulders after surgery, I don't like them. They're hard because they don't tolerate anything. They can't move. They won't do it. What's the difference? Well, Chris felt alienated and unwanted by his employer. They weren't communicating with him. They were putting him off. He didn't feel like they were working on his behalf. Sam felt empowered and wanted. Immediately sent on light duty. Literally from day one, light duty. Hey, Sam, get your pants on in the morning. Get your boots on. Show up on the workplace. Okay? Total cost of case is exponentially increased by the time factor. 7 months versus 18 months. Can that happen? Man, it does. Shocking to me. I'm always amazed when it does happen, but it does. Pearls for the employers. Communicate clearly and constantly with your injured employee. Can't say it enough. They are hearing information from voices. They're hearing it from television. They're hearing it from their buddies at work. They're hearing it from people at home that have had similar surgeries or similar problems. So be the loudest voice. Let them know. Talk to them. Communicate even when you don't feel like you need to communicate. Talk to them. Minimize wasted time during the case. You're using a PT clinic that takes 4 weeks to get somebody scheduled for an eval. Find a different PT clinic. That's not okay. That's money just straight out of your pocket because it's time. Are there clinics that take 4 weeks to get in? Yes, there are. Frequently. It's crazy. That's wasted time that you can help as the employer. Utilize modified duty work program. Get them at work. Get them doing their normal deal. Utilize post-offer employment, return to work testing. A little bit of upfront on the cost of those things, but it's going to save you money in the long term. Questions about those two cases? So Chris would have had a permanent partial. He would have had a permanent partial disability because his motion was never right. So that would have been his MMI. He would have had a permanent partial, and that would have been settled after that point. Maximum medical improvement. So that's the time where they say, hey, we've done everything that we know to do to make this better. They've exhausted the physical therapy. They've exhausted rehab. They've done the FCE. We're at the end. That's the end of treatment at that point. So, and that's just a term that they use. MMI, it says the end. Oftentimes your MMI will be an independent medical evaluation, probably not by the physiatrist or whomever was directing care. Typically, they'll send them to someone, another provider for that MMI determination, that final determination. Great question. Thank you. Other questions? Everybody tired? Anyone stand up for a minute? Please do. Oh, we got another one? Yes.
Can you explain a little bit about how you would use the post-offer employment testing and a return-to-work testing as a comparison for like establishing the baseline if maybe they've been there for 10, 15, 20 years and and life has taken place?
Yeah. Okay. That's a great question. Did everybody hear that question? So let's say, how are you going to incorporate a return-to-work physical or their post-offer employment if that patient has been employed there for 10 or 15 years? Now, are you saying how are you going to compare their determination to their motion at the end, like comparing their post-offer performance? Sure. On something that's clearly, that's a great question. How would you compare it to baseline? So the post-offer employment testing, and we're going to talk about that here in just a few minutes in depth, but the post-offer employment testing allows me to take measurements of what they have available. So on date of hire, if I do post-offer testing for the positions at my company that have the most injuries, I don't have to test everybody in my company, but I've looked at one job and said, this is where my people are getting hurt. We're going to do post-offer testing for these folks. You can do that. So I've got baseline information on them. If they've worked for you for 10 years and they had no history of shoulder problems at the onset of their hire date, and their motion was good on the hire date, you own it. I mean, you own it. You know, that's going to be on you. Now, let's say 10 years later, if they'd had a rotator cuff previously before hire, and they declared that on my medical questionnaire of their post-offer test, and in my measurements, I could demonstrate that they had 130 degrees of shoulder flexion and they had 110 degrees of shoulder abduction, then yes, I can use that for appropriation at the end. Does that answer that question? Sure. So the question is, there's going to be some degeneration there present after 15 years? Yes. In this case, it wouldn't matter. Where it would matter more is your short-term, your new employee that works for you for 6 weeks and had a previous surgery and some limitations and a work comp case that was documented. It's going to be much more valuable. I mean, this is obvious. These two cases, I made them such that they're obviously the direct result of their work injury. There's no real appropriation. They fell. These are traumas. So I tried to kind of make it a little bit less muddy because those do get very muddy. Who's had that happen before? Employee comes to work. They pass a pre-employment physical. 6 weeks later, they've got a back problem. Got a herniated disc. Worked for you for 6 weeks. They don't lift over 30 pounds at their job, but now they've got, and now you feel stuck. So they've got an MRI, and now we've opened Pandora's box. Oh my gosh, they've got 3 annular tears, and they've got disc herniations at 4 levels. They probably do. You're 55 years old and you've done manual labor, you probably have some of those findings. For sure you do. So that's where it gets a little bit more muddy. How do you appropriate those things out? Great question. Still don't think I answered it very well. Okay. Post-offer employment testing. Here we go. Why should we do a post-offer rather than a pre-employment test? What are we going to test? Who are we testing? Who performs the testing? And what are the benefits? The reason that we do post-offer employment testing is to determine, and this statement has a lot of information in it, to determine if new hire employees are physically capable of safely performing essential physical demands of the job to which they are applying. So that pretty much unpacks the whole deal. New hire employees, physical capability, safety in performing, essential physical demands. So I can't just say, hey, let's just make some indiscriminate, you got to lift 300 pounds above your head. Can't do that. They have to be essential physical demands of the job to which they are applying. Okay? Post-offer or pre-employment. Who has done pre-employment testing in the past? Has anybody done pre-employment testing? Right? Okay, yeah, some hands going up. We used to do pre-employment testing. Pre-employment testing is a traditional screening. It's performed after the application for a job. It's typically a non-medical test. It's less expensive. We're not taking a medical history. It gives us a limited baseline of information regarding some physical testing. So some lifting, a push, a pull, a carry, that sort of thing. It's a go or no-go pass criteria for specific abilities or job tasks. That's your pre-employment physical testing. Post-offer testing is performed after the applicant has been made a conditional offer of employment, which is contingent upon the results of the post-offer disability questions or medical examinations. So it's medical in nature. The people that are conducting the test should have some fashion of certification. It must be administered to all applicants for the defined job category or description, regardless of disability. So I mentioned a little bit earlier, you may recognize certain job descriptions that have the majority of your injuries. So let's say it's second shift dock laborer. Man, those guys are hurting their backs a ton. We've got to figure something out on that deal. So I can decide that anyone who applies for second shift dock laborer, we're going to do a POET test for them. And everybody that is hired for that job has to do that test. I don't have to do a POET test for every employee for my company. I don't have to do it for everybody. I have to do it for everybody that I've defined as that job description. So you have to do job descriptions, number one, right? I have to have formal job descriptions. It allows for a thorough medical history. So with the post-offer testing, we can ask a lot of questions, and we can gain a lot of information about their motion, their abilities, whether or not they can do those essential job functions. So we can ask all this stuff. Workers' compensation history, prior sick leave usage, which I thought was pretty strange. So it would be a strange question to ask. I can ask that stuff. Illnesses, diseases, general physical and mental health. If they're screened out due to disability, you as the employer must show the exclusionary criterion is job related and consistent with business necessity. Okay? Medical history, HIPAA, we have to keep that stuff confidential. It can't be kept in their general file, right? We've got to be compliant with that stuff. Government's going to come and get us, fine us. Here's the beauty of the post-offer testing, in my opinion. It allows for a more robust baseline of physical function and capacity. This is, to me, the best part of it. One of the questions that I hear a lot from employers are, why should I do post-offer testing? Everybody passes them. Everybody passes it. We've had this test. We've never had anybody fail it. Well, maybe we need to look at your test. Maybe we need to examine that or redo your test. But really, to me, the goal is that now I've got information that can help for appropriation later on in case of injury later on. So I can ask if they've had back surgery. I can take measurements of their spinal motion. If they've had a total knee replacement, I can baseline that. So they don't have full motion. What do they have? I've got day one where they were at. So if they're injured in that body part again, I can help to appropriate what my responsibility is. Oh, look at that. We rehabbed you and you're back where you were day one. We're not back to normal for someone that's not had that surgery in the past, but we knew you had it. We're responsible to get you back where you were. So it can help with appropriation. That, to me, is the best part of it, because I'll be honest, most of the folks that we have that come in and do them, they're going to pass the test. I might be able to, I say might be able to, it's not like I'm trying to fail somebody, but if we get really picky on body mechanics, you could probably make, on some of the heavier stuff, you could probably make some comments and say, yeah, they did it, but it was not safe. You know, they're putting themselves at risk. So you might have a failure on that. But we do, I'm thinking of one test in particular that we do in Springfield, and it is awful. It is unbelievable. I could not pass it to save my life. And it's super hard. And occasionally we'll catch some grief because somebody passed it. You know, my point there is that people can pass things sometimes that you wouldn't necessarily think that they might be able to. But it's not my responsibility to exclude people. I can't discriminate against them because of their age or their color or their size or their gender. Can't do that. So one of the downsides to your post-offer testing is it is more money up front. It's more expensive because we're using skilled people. What are we testing? Specific physical demands required by the position. How do we know what those demands are? How am I going to find those things out? Miss Melissa knows the answer to this. So hopefully we have a written job description that has these. We've identified these essential physical demands. So somebody's going to have to go on site and measure these things. We need to know, how heavy is it? What does it weigh? What position are they in? Do I have to push, pull, lift, carry? Am I up and down ladders all of the time? Am I in a kneeling position? We need to see how often and how much they're doing. We get just a lot more information on the post-offer tests. Get that previous medical history. That's what we're looking at, that stuff. The medical history is of the applicant only, or the potential hire rather only. We don't look at family history. That's forbidden by the GINA Act. So we can take measurements, range of motion, strength. And to be honest, normally we've kind of gone to the process of now I'm measuring just about everything. I'm looking at shoulders, I'm looking at knees, I'm looking at their cervical spine, I'm looking at their lower back. So I have pretty good idea physically where they're at on date of hire. Other testing considerations. Depending on what your jobs are, you may have these other things that you need to test. Lead exposure, pulmonary function testing. Anybody have to do pulmonary function? Anybody do pulmonary function testing? Yeah. So there's a few. Some over here. Specialized vision testing. Audiograms. Anybody do frequent audiogram? Have an audiogram testing program? Yeah, that's one that you see and as a potential hazard. So nice to have baselines of those things. Are baseline spinal x-rays necessary as part of testing? X-rays. What do you think? Yes, no? Anybody venture to say? Let's go to the next one here and see. It's a bad predictor. Again, X-rays show bony approximation. Doesn't give us any insight into the soft tissue, which is likely the biggest problem anyway. We're exposing for radiation. Are they necessary to determine if the applicant is able to perform essential job functions? So in this case, I would say no on the X-ray. EFASTM, anybody do these? Electrodiagnostic function assessment, soft tissue management programs. Anybody do these? No, I don't think so. Don't see many of these. Baseline assessment, looking for baseline nerve function and repetitive use and trauma. So, I mean, jobs that I would think might be reasonable would be processing plants, probably, where we're doing a lot of repetitive gripping. We're looking at baseline, median nerve conduction, ulnar nerve conduction, those sorts of things. Again, it has to be in a secure database. They're used only in the event of a future worker compensation claim or when post-loss assessment is necessary. And again, it's good. The testing is good. It's helpful. It's useful. It doesn't discriminate. It's separate from your POET test. It's not used to determine if they can perform their essential job functions. It's different. It's a baseline of nerve function. So you can also do it on your current workforce as well as new hires. Yes. Question was, why wouldn't an X-ray considered to be a baseline for the spine? It only shows us, now in the event that you had somebody that had a huge disc herniation that deteriorated over a 10-year period, yes, you would be able to see some differences. You'd probably be able to see some spurring that would occur as well. But that still isn't, you can have horrible bone spurring, you can have complete loss of disc height and not have nerve-related symptoms with that. So it's just not a predictor. It's not a predictor. It can be useful. It can show changes, but those changes, as we know, how many of you have had someone with a disc herniation on MRI that didn't have leg symptoms? Now they're worried about a disc herniation. I didn't have any leg symptoms, but they did an MRI. What now? Oh no, I've got a disc herniation. right? So now I know that I have it, now I'm scared to death. Never going to bend over again. I've got a disc herniation. Didn't have leg symptoms. Research shows that 2/3 of people with no back pain will have a positive MRI. 2/3. Take 1,000 folks, do MRIs on 1,000 people with no history of back pain. 2/3 of you have a mild disc herniation. So don't ever tie your shoes again. I'll just leave that out there for you. Okay. Who are we going to test? We talked about that. All applicants for a given position which you have conditionally offered a position. All applicants for that job. Everybody gets it. Question number 1. You have established a post-offer employment test for position of night stockman number 1. The position requires constant material handling up to 50 pounds, as well as frequent push-pull of up to 75 pounds. So pretty heavy. Your buddy calls and says, hey, my son's home from college. Johnny needs a job. You know Johnny. Johnny's a middle linebacker for the MSU Bears. He's a stud. He can bench press 225 for 15 reps. Does Johnny need to do a POET test? Yes, Johnny does, because that would be discriminatory if you didn't give him one. He has to do it. Okay? Who's going to perform the test? Healthcare professional. Usually it's a PT or an OT, occupational therapist. It could be a PT assistant or a CODA, a certified occupational therapy assistant. Those are acceptable. Whoever is doing the test should be competent in examination, evaluation, performance of physical demands testing. And then you may have to go to an audiologist for your audiogram. There's some other folks that might come into play too. Testing to the physical demands of the job. So we talked about that again. Your job description should have a accounting for what the physical demands are. If you send me a job description and it's awesome and it's got all of these demands, I can do a test for you without coming onto your property. Maybe I shouldn't, but I can. It's not best case scenario, but I can probably do one. I did one recently where somebody sent me, they were trying to get one done. Nobody would touch it because they wanted to send somebody out. And I'm like, hey, they've got a job description that is very descriptive. It has all of the essential functions. Tells me how much weight. I can do that test for them. It was a one-time deal. No, it's not hard. We can do that. If I don't have a job description, I can't do this. Cannot do this unless somebody has come out and looked at these jobs. Now, if you are adept at that as a manager, you can go and measure these things. You can measure table heights. You can measure forces. How much force does it cost? Or how far do they have to carry? How far are they pushing? How far are they pulling? You can do this and make that job description. The better your job description is, the less work it is for us when we come out. Questions on that stuff? I don't recommend that. I don't recommend that you do it. I'd rather you pay us to do it. Right? Job security for me. Importance of we talked about this, formal job descriptions, physical demands analysis. They must be essential or mandatory. So I can't, if I've got a moving company, I can't just indiscriminately say, hey, we need to hire only guys that are 6'3" and can lift 250 pounds from the floor. You can't do that. I have to go out and measure that. Now, if you have to move a piano, if that's an essential job function, I can say that. I have to lift 50% of a piano, get it off the floor, it has to clear the floor. I have to be able to carry it for 10 feet. I can say that, but I have to test it. I can't just make indiscriminate determinations. Hey, I want everybody to be super strong and be able to do big weight. Has to be an essential function of their job. The weight, effort, work level should be quantified rather than approximated. We're not guessing. We need to take real measurements on this stuff. Here's your OSHA work classification table. Sedentary, 10 pounds or less. Light work, 20 pounds occasional, 10 pound frequent. 5 pounds constant. Medium, 15 pounds on a constant rate. So that's available. You can find that online. I don't know that you'd want to know that, but it's out there. That's out there. Occasionally, we break it down. How often do you have to do something? Occasionally. So if I have to do it 1% to 33% of the day, that's occasional. If it's frequent, it has to be 34 to 66% of my day. So that breaks it down for you. That kind of tells you what your work classifications are for different positions. Workflow of the test, pretty simple. Patient comes in, or your prospective hire comes into the clinic. We're going to give them a medical questionnaire to fill out. We're going to go over that questionnaire. We're going to follow up questions regarding what the history shows. So if they've got some medical history that I have further questions about, if they tell me that they've got a a permanent partial disability, I'm going to follow that up. I'm going to document what is it, how much is it, who's the doctor that gave you that permanent disability rating, how many pounds is it. If they tell me they've got back problems, have you had back surgery? When was your surgery? What kind of surgery was it? I can ask those things. Goniometric measurements, that's a great word, just measuring angles of joints. Anthropometric measurements about their body, movement. Okay, I'm gonna have them perform these essential job functions that we've outlined that they have to be able to do. Then I'm gonna submit the report. I'm gonna take it, fax it to the employer. I don't hire people. I don't hire people. I conduct a test and send the results to you. You hire people, right? That's not my job. So don't get mad when you call and say, do I hire them or not? That is your call. Compliance considerations, boring stuff. You want your reports to be compliant. We'll just leave it at that. All kinds of compliance considerations that can get you in trouble. It's boring stuff. Some ADA questions. Does a job offer have to be limited to current vacancies? Current vacancies. Nope. You can give job offers to fill current vacancies or reasonably anticipated openings. An employer give offers that exceed the number of vacancies or reasonably anticipated openings. So we're reasonably anticipating that there's going to be some openings. Yes, we can do that. They are real offers. If you can demonstrate that the need to give more offers in order to actually fill vacancies. We have an employer in Springfield. They send over a ton of people at a time, and at the end of the day, 3 of them are eligible for hire. We do them en masse for that company. So, if can I use my POET test? Here's a great question. Can I do my post-offer employment test for my return to work physical? What do you think? What do you think? There's not a wrong guy. I'm not going to tell you you're wrong. I think you can pretty close. Not always, but you sometimes can. And that would be helpful. That would be helpful for your employees that have been there for 25 years and they have to do so let's say you have an employee that's been there for 25 years and needs a total knee replacement. What do you do with that person? Can they do their eventual? We don't talk about that stuff very often because that's not workers' compensation. But that's real. What if he's a lineman and has to climb? He has a total knee. Can he do that job again? Well, I have a POET in place that says that these are the essential job functions. Can I test that employee? If I make it a policy, I can. So now it's out of the work comp. Now it's you had to have a rotator cuff on your own dime and you're trying to come back to work. Can I test them? If I have a policy in place, I can. That can protect you too. That's a tough deal though, because what I get into with employers on that is they've got an employee that they love, but they've got a policy in place that says that they've got to pass the return to work or a fit for duty test, and they've got 3 years till retirement. Do you really want? You have to. If the policy is that they have to do a return to work test to come back to employment after an elective surgery, they have to do it. And that's a tough one. Those are tough choices. I got into that recently with an employer. That was a hard one. Because once the policy's there, you have to do it for everybody. You can't pick and choose. You know, oh, John's a jerk. I don't want him to come back. Let's test him. Right? You may want to do that. Employers call us with that all the time. Hey, we want to do we want to start POET testing because we got this guy that had surgery and he's a real jerk and we want to get rid of him. You think I'm kidding. I get far more calls for that than I do through the other way. Okay, that's enough. Any other questions? Let me field a couple of questions about POET testing and we'll shut it down. So where do you go? Yeah, the question would be, where do you go for that information? I would use whoever is doing your post-offer testing. I mean, they already have your post-offer test in place. If you're making that a policy, then I would use that same vendor. I mean, because they're familiar. They know what the essential functions are. They've got all that information on file. They're not going to have to learn it. They're not going to have to seek it out. That's who I would use. If you don't have the post-offer testing, you're on your own. That's why it's important. That's what you got to have it. You've got to have it. Or you can seek out someone to do return to work testing only and have a policy that addresses that. You can do that. But it would be the same type of clinic that does post-offer testing can do your return to work physicals as well. Yeah. Great question. I think we made it. We good?
All right. Help me thank Mike for his presentation.